ഏറ്റവും പിടിച്ചോ മടക്കി പിടിച്ചോ വിടല്ലേ
Except for
ഇത്
hallucination
മടക്കി
also
പിടിച്ച്
also.
കീഴോട്ട് വിടല്ലേ അതേപോലെ ഇത്
Invasion was weak, but more weakness was observed in the eventers. Hip abduction was also weak bilaterally. EJ was well acceptable. Angle jack was absent. So this is the finding. There is no obvious sensory findings in this patient. SLR was negative. This is the gait of the patient. He couldn't stand on heel or toes, but she could stand on heel walking was actually better than the toe walking. So this is the patient. So examination findings were confined to the lower limb, mild contraction of the tendo Achilles, power, weakness of dorsiflexus, plantar plexus, EHL, and flexor hallucis longus. Both inverters and reverters weak bilaterally. Weakness of hip abductors. External metacarpophalangeal joint in the big toe appeared normal. DTR, knee jack normal, angle absent, sensations normal, SLR negative. So what do you think is the likely site of lesion diagnosis? Okay, I'll go further. Suspect a bilateral face of radiculopathy because it fits in with the distribution. So there is lumbar spine was normal, MRI was normal. Its conduction study was also within normal limits. The EMG done from outside was reported to show innervation from the abductor hallucis and peroneum. So what is the odd thing in the examination of this patient, which clinches the diagnosis? Pardon?
There is no weakness at the metatarsalphalangeal joint.
Okay, that's the point. So that means EDP was normal. There was no weakness or hardly any weakness in the metatarsalphalangeal joint, but EHL was weak, flexor hallucis longus was weak. That means the leg muscles were weak, but the short muscles of the feet were normal. No weakness in the extension of the metatarsalphalangeal joint, suggesting EDP is normal. If it is due to neuropathy or radiculopathy, why should it spare the EDP? So patient was examined again. She was also found to have weakness of the adductor hallucis. Sorry, sparing of the adductor hallucis. At the intrusive were also found. But the dorsal plexus, everything was weak. So small muscles appeared normal. So what do you want to do now? CPK was 2675. Suspected dysphenopaly, perimyoshi, and it was confirmed by plain chromosome sequencing showing the Miyoshi map. So the lesson is that in a person with distal muscle weakness, if you find that leg muscles are more affected than the foot muscles, think of a myopathy in this patient, myopathy in those patients. Now, the story of a 64-year-old diabetic lady. She had presented with numbness and pain in the right lower limb for the last 3 months. She came in a wheelchair because of the pain, and she resisted to get out of the chair because she was screaming with pain. So I have to examine her in the sitting position in the wheelchair. This was the examination finding. The inversion, the dose was over normal. I'll show the video once again. Dose is weak. Plantar plexus is weak. That was normal. So on examination, she had foot drop with weakness of dorsiflexus, extension and flexion of the big toe and plantar plexus. Her inversion, the dorsiflex position was normal. Both angle jerks were absent. Sensory examination inconsistent. Where is the lesion? Is it diatic palsy or L5S radiculum? Any thoughts?
I think
Tibialis anterior is normal, sir, because she could do.
Very good. So that's the point. Tibialis anterior was normal. So what does it give? What is the clue? I mean, how does it help you in differentiating the two? What is your diagnosis now?
This is predominantly L4, sir.
Yeah. So tibialis anterior is predominantly L4. So it will not be spared if it is a sciatic nerve palsy, because that will be also be affecting convener nerve or sciatic nerve. So that means that if the lesion is L5 and radiculopathy, sparing the L4 route. So that's it's a normal power. So yes, this is what the MRI showed. Multiple disc prolapse, mainly L4, L5, L5, S1 region. Now I'll go to the third case, third situation. All of you know about the HINS and HINS plus to differentiate acute peripheral vestibulopathy from central causes. But HINS has its own limitations. Positive head thrust can occur in central lesions, especially in vestibular root and zone lesions. Unidirectional nystagmus, which is classical of side beating nystagmus, I mean, beating only to one direction, or direction fixed nystagmus is classical of peripheral vestibulopathy, but can also occur in lateral lesions, so-called pseudovestibular neuritis. Skew deviation, which is seen in central lesions, may not always occur in central lesions. Sometimes it may not be there. So by these, we cannot totally differentiate acute vestibulopathy from central lesions. So let us see one case. This 56-year-old man presented with acute onset of vertigo and imbalance for the last 2 days. This is the video of the patient. He has got nystagmus beating to the right side, or looking to the right, as well as looking to the left side. It is a direction fixed nystagmus. The beating to the right, favoring a left peripheral vestibulopathy, because first component is beating to the right side, or looking to the right as well as looking to the left side. So is it central lesion or a peripheral lesion? Here the head thrust equal was very positive because it did not cooperate very well for that. So what other test would you like to do? Differentiate the two.
Lateral position.
Yeah, skew deviation is one which you can look for, but it is not very convincing. Skew was not there.
Lateral position.
Ah, that's very good. That's the thing which I did. See, look for its lateral pulsion to the left side. That tells you he had a left lateral lesion. Okay. Yeah, this can occur with left lateral lesion or a right paramedian pontine lesion, but here it is the left lateral lesion. Now, often this sign has not been mentioned in HINS plus. HINS plus means the 3 tests in HINS along with presence or absence of deafness as well as the presence or absence of significant gait ataxia. That is the HINS plus. But this is another useful sign which you look for. Somebody can very easily differentiate whether central versus peripheral, because saccadic lateral pressure will not occur with a peripheral lesion. So this patient had a left. So he is infarct in the lateral middle. Now, problems of ptosis. Many times, patients with ptosis are referred from ophthalmologists to us to rule out myasthenia. In my next few cases, I will show various cases of ptosis which are referred to rule out myasthenia. All of them are referred to rule out myasthenia. Now, what do you think about this girl with ptosis with the normal extraocular movements? She had ptosis on the left side. It is not correctable.
Okay.
The ocular movements are all normal. Okay, now next video I'll show one sign which tells you the diagnosis. It is just look down from above. So what did you observe? I'll show the video once again. Look carefully what is happening to the left hand. It starts to look up and slowly look down. You can see the sclera visible above the cornea on the left side. Eye with the toast eye. That means
With lag.
there is a
Thyroid,
Suggesting what?
thyroid ophthalmopathy.
No, thyroid ophthalmopathy will not produce ptosis because
Contracture of the
it's as a contracture of the levator papilla superioris. Now, thyroid ophthalmopathy, take this point, thyroid ophthalmopathy can produce ptosis only if there is associated myasthenia. Because thyroid ophthalmopathy is a restrictive ophthalmopathy. There, the apparent weakness is not due to the weakness of the muscle, but because of the infiltration of the antagonistic muscle, which prevents the agonist contraction. So, for LPS, as far as LP is concerned, there is no antagonist in the ocular muscles. So, if there is a contracture infiltration like LPS, it will produce lead retraction and not ptosis. This girl has ptosis as well as lead retraction, telling you that there is a fibrosis LPS in addition to the weakness. That
lid decrease.
That means it's a congenital ptosis. So this is linear to any investigation. If you find this finding, we can straight away diagnose it's a congenital ptosis. So this congenital ptosis, what is the diagnostic clue? Lid lag in the ptotic eyelid. Now see this old man with ptosis since childhood. Again, we are not sure how long it has been there, whether we want investigation or not, we are uncertain. Here ptosis in the left eye.
ഞാൻ പറയുമ്പോൾ വാ തുറന്നേച്ചാ അടച്ചേ വാ തുറക്ക് അടച്ചേ.
So look for, in a patient with congenital ptosis, also look for Marcus phenomenon. If you find a positive Marcus phenomenon as in this man, you can definitely say that it is congenital. You need not do any investigation. Straight away you can diagnose this is set. So these two tests don't forget to do in the patient. Yes, please. Anyone want to ask questions?
So the jaw wing phenomena similarly appears in the same way, right?
Yeah,
Jaw
jaw wing phenomena indicates there's a congenital aberrant reinnervation from the fifth cranial nerve to the third cranial nerve. That can occur as only as a congenital phenomena, not as acquired phenomena. It is not the aberrant reinnervation occurring in the seventh nerve. This is two different cranial nerves.
Can we see the video again?
Yeah, please. Anyone you want to see the video or anything, you can ask me, please.
ഇടത്തിരിക്കെ ഞാൻ പറയുമ്പോൾ വാ തുറന്നേച്ചാ അടച്ചേ വാ തുറക്ക് അടച്ചേ.
So that's the Marcus phenomenon. So look for these two, that will make the diagnosis. We need avoid unnecessary investigation. So, okay, this is already mentioned. Now, this lady has come with fatigable ptosis. This is she's got a correctable ptosis, totally corrected. This is on looking down. All ocular movements were normal. I'll show the video once again. This is a ptosis on the right side. It's correctable. Looking down is the eyelid position. So what is your diagnosis?
LPS disease.
Very good. Now this is LPS dehiscence, levator dehiscence. Now what are the points that later on? The ptosis is correctable. A correctable ptosis tells you that the levator papilla superioris is intact. It can occur only in two situations. One is Horner syndrome, as you all know. The other is levator dehiscence. Levator dehiscence, the levator muscle itself is normal. Only thing is attachment is dislodged. The distance between the eyelid crease and the lid margin is increased. Looking down, the right eyelid margin is lower than the left. I shall show each one. So here the first clue is that the distance between the eyelid crease and the lid margin is increased. Second clue is that ptosis is correctable. Third clue is that on looking down, the lid margin is much lower than the normal eye. On the other hand, if even in third nerve palsy, you find that you're looking down, that will be equal line, or in the same on the opposite side. So fatigable ptosis, also known to myasthenia, can be seen upper neurotic ptosis. So what are the features suggesting elevate position? You can see high skin crease more than 7 millimeter of the lid margin. Normal escalation of the eyelid, telling you that LPS's function is normal. Then compare the lid position in up gaze, primary position, and down gaze. Elevated in the sense the ptotic lid is lower than the normal lid, not only in the primary position, but also in the down gaze. In contrast, in myopathic and neuropathic ptosis, lid position is normal on the down gaze. See, for example, this is a case of elevated descent on the left eye in this patient here on the left side. And this is the patient with third nerve palsy. What you find is that, see, on looking up and primary person, there's a marked ptosis. But looking down, what happened? The lid margin is equal on both sides because looking down, the levator is not acting. So it does not matter if the levator is paralyzed or not. The lid position will be lower. So on the other hand, it will be lower compared to the normal side in the case of elevated excess. Okay. Shall we go to the next one?
Yes, sir.
Yeah. Now, history of a 61-year-old female, history of defective vision for the last 1 year, which gets better when she manually elevates the eyelids. These are all cases of ptosis only. Her husband noticed bilateral drooping of the eyelids for the last 3 years. This is the lady. She had bilateral ptosis.
അത്രത്തോളം മുകളിലോട്ട് നോക്കാം, അത്രത്തോളം നോക്കണം കേട്ടോ.
There's no fatigability. Ocular movements are all normal. So what could be the possibility in this patient? She had bilateral non-correctable ptosis, suggesting that LPS is affected, is not fatigable, unlikely to be myasthenia, symmetrical. Extraocular movement is normal. So what do you need now? RNS was negative, ISPAC test was negative. So what else you want to do now?
Previous photographs, sir.
Yeah, previous photograph at 25 years, she has got ptosis, not only previous photograph, that means, then what else? Seen the family members. This is her elder sister who has got bilateral ptosis. This is her mother who has got bilateral ptosis. This is her daughter who's also got bilateral ptosis. Sometimes ptosis can be familial. So even if the patient is not having it, photograph is not available, you can always screen the family members to find out that the ptosis is congenital familial or not. So it's a kind of simple kind of ptosis which is in families. I think this I will skip, the details I will skip. Can be unilateral, bilateral. And this lady also came with ptosis. Look at the ptosis on the right side. Is it ptosis or the lead retraction on the left side? It's also got restricted upward movement. I'll show the video once again. Is it plus minus syndrome? Or is it ptosis on the right side alone, third nerve palsy? Or is it lead retraction on the left side due to some other cause?
Myasthenia, sir.
Okay, how do you know that?
Because we have to, close the other eye.
Okay.
Or,
Yeah.
close the ptotic eye.
Yeah. To find out, we want to know whether this left eye lead retraction is really lead retraction or due to a compensatory phenomena secondary to the, or not compensatory, secondary to the overaction of the frontalis. See, the myasthenia, ptosis of any kind, so for example, due to third nerve palsy, whatever it is, usually in myasthenia, the patient tried to overcome the ptosis by elevating the frontalis. In that attempt, the opposite eyelid, which is normal, also get elevated. To find out whether this lead retraction is genuine or not, this is what you have to do. You close the affected eye. See that lead retraction disappeared. Once you open the right eye, lead retraction appeared once again. So that tells you that there is no true lead retraction at all. It's only ptosis in the right side, and this sign is classically described in myasthenia, ocular myasthenia. This is called the pseudo von Grief sign, or the pseudo lead retraction myasthenia gravis. And ptosis is not always due to third nerve palsy or Horner syndrome. A 16-year-old hypertensive was found unconscious, quote unquote unconscious, by the relatives in the early morning. This is the video the patient is conducted. Opening the
കണ്ണ് തുറന്ന് പിടിച്ചേ. ഇനി ഇടത്തോട്ട്, ഇടത്തോട്ട്, വലത്തോട്ട്, ഇടത്തോട്ട്.
And he has got left hemiplegia. And he has got bilateral ptosis. So, where is the site of lesion?
Cerebral ptosis.
Pardon? Yeah.
Cerebral.
Yeah. So, not with brain because he has got a gaze palsy to the left hemiplegia suggesting a right hemispherical lesion. So that this is what you find in the CT scan, had infarct in the right MCM. This is what is called cerebral ptosis. It has been described with either right or left hemispherical lesion, usually the right. Lesion is usually infarct in the MCM territory. And the right hemispherical lesion usually produces bilateral ptosis. Left hemispherical lesion produces unilateral ptosis, which may be either ipsilateral to the lesion or contralateral to the lesion. This boy was also referred to rule out myasthenia. What do you think is the boy's cause of the ptosis? The ptosis is the right eye. Now you look up. It's got. Okay. What is the diagnosis?
Non-organic.
Non-organic.
Psychogenic.
Right, very good. The clue was that you look at the eyebrow, it's actually an apparent ptosis is not due to the ptosis. If it is real ptosis, you would have tried to elevate the orbicularis, elevate the frontalis contraction, but it is frontalis is down. That tell you it's actually the ptosis is actually not ptosis, but due to the overactivity of the orbicularis. So the orbicularis can be due to many reasons. Can be due to blepharospasm, but here it is due to the functional ptosis because of this phenomena, which I will try later on. Looking up again, more constriction. And it's got a so-called quivering contraction of the orbicularis. That gives a clue. So, look for the quivering contraction of the orbicularis. If the patient attempts to elevate the eyebrow or look up, this action might increase the contraction of the orbicularis oculi. That is the one clue to suspect it is a functional blepharospasm. Otherwise, it can also occur with blepharospasm due to focal dystonia. And excessive orbicularis activity can be mistaken for ptosis. Can be either involuntary as a hemifacial spasm, aberrant regeneration following Bell's palsy, or residual blepharospasm. It may be voluntary as in functional blepharoptosis. In functional ptosis, recognizable by normal elevator function with apparent weakness of the frontalis and overcontraction of the orbicularis oculi. How to solve the problem? Organic unilateral ptosis usually associated with frontal overactivity, whereas in pseudoptosis is persistently depressed eyebrow, the variable inability to elevate the frontalis, overactivity of the orbicularis, and photophobia is characteristic. Now I'll go to the next case. The ptosis is over now, collections of ptosis. I'll go to another case. Now this is again another case of ptosis. This patient came with state inability to open his eyes after closing for last 3 months. This all I will show you. Has to close the eyes. So what is the diagnosis? Is it apraxia of eyelid opening?
Palpebral part of the palpebral type of
Yeah, this I have shown before. The diagnosis, it may be confused with apraxia pallid opening. I will show this video again. The real apraxia pallid opening. It's trying to open. It's trying to open it. This is the apraxia pallid opening. The clue was that look at the lower eyelid. Ask the patient to open the eyelid. The lower eyelid contracts. It's equal. That will never occur in a case of apraxia pallid opening because an apraxia pallid opening is only a opening apraxia. Nothing to do with the contraction of the orbit iris oculi. So sometimes it will be confused because when the focal dystonia or blepharospasm is confined to the purple part, it can be confused with apraxia pallid opening. They always look for the lower eyelid. Another case of apparent ptosis. You look at the eye on the right side, it's got ptosis, but look at what is happening to the facial muscles. What do you observe the facial muscle? It's got a myochemic contraction from out of the facial muscle, causing an apparent ptosis because the overaction of the frontalis again. This patient had pontine glioma. Now the ptosis is finished, or apparent ptosis is all finished. Then I'll go to this case. This 34-year-old lady has presented with gait ataxia of 3 months duration. The following findings in the ocular examination confirm the diagnosis. Tell me what is the finding. So what is the diagnosis?
Bilateral IN.
Very good. The thing is that sometimes when you look at the eye, we tend to look only at the eye. We cannot see both eyes together. No? We can only focus on one eye. So in that case, what you do is that sometimes you may not be apparent. So here it is a severe degree of slowing. So you can find out the adduction lag very easily. But sometimes it may be so subtle that sometimes it may be difficult. In that case, what you do is that don't look at the eye, look at the bridge of the nose here. I'll do the same again. Now fix your eyes at the root of the nose and observe the velocity of the eye movements of both eyes simultaneously. Don't look at the eye, look at only at the root of the nose, and now you can see. Now you can easily make out the adduction lag. The slow velocity of the adduction is less compared to that of the abduction. Is it apparent now? It's obvious now?
Yes, sir.
Yeah. You want to see video again? No? It's okay. So the adduction lag. Now sometimes this when you get adductions INO, sometimes you have to get confused with myasthenia. Remember, myasthenia can exactly mimic that of an INO. Can even produce abduction nystagmus. Adduction slowing can be demonstrated by both. This is how to differentiate between the two. The adduction slowing can be demonstrated with both large and small amplitude eye movements in the ear. In contrast, the adduction deficit due to myasthenia gravis, the small amplitude middle rectal saccades show normal or supranormal saccades or supranormal velocity. But irrespective of the amplitude of the saccade, it will be slow in the case of IN, whereas it will be different in the case of myasthenia. This is a technical point by which you can differentiate true INO versus pseudo INO. Very often we come across patients with diplopia with the normal eye movements, especially vertical diplopia. Most of the time in the OPD we come across this problem. So this 60-year-old diabetic came with diplopia and looking with the left side. On examination, the extraocular movements appeared grossly normal. In fact, I was considering whether this could be early left sixth-minute paralysis. Then he showed me a paper and told me this is how he saw the images. This is how you saw the number plate of his car. This is how you saw the tube light in his room. So what is the diagnosis?
Right superior oblique.
Pardon?
Right superior oblique. Superior oblique.
Which side?
Superior oblique.
Which side?
Right side.
Right.
Okay. This is right side. So when you got a problem in making a diagnosis of superior oblique, sometimes it's very confusing. Everywhere you will say double, sometimes say not double. Or you'll make it confused. So this is a very simple thing you can do at the bedside. So unilateral fourth nerve palsy will see a horizontal line and a second line tilted line above or below, usually below it, intersecting the side of the affected eye. I think I will skip these things. So what you do is that patient should be asked to look at a straight line on a paper, which is placed below and to the right and to the left side. Show the line on the right side as well as to the left side. The diplopia is present, he should be asked to draw the false image. If the false image forms a line below and tilted with arrow to the side of palsy. For example, if the arrow is pointing to the right side, it is right fourth nerve palsy. Arrow is pointing to the left side, it is the left fourth nerve palsy. Now, the lower one is the false image. Why it is going in this direction? Suppose imagine patient's got the right fourth nerve palsy. You know, fourth nerve palsy, the superior oblique is an indort residue. So the right eye is extorted. When the right eye is extorted, the image which it perceives is intorted, the other way around, to the opposite of the rotation. So it will come down. Eye is to the rotate to the right, so in this case, but the image will be to the opposite side. That is, it forms an arrow like this. Okay, so that tells you this is a very simple bedside thing you can do. I found it very useful in my practice where I couldn't make out a definite ocular movements restriction on examination. And the separation of the images increases when the head is tilted to the side of palsy. Now, this patient who is a chronic alcoholic developed recurrent vomiting for 2 days and admitted in local hospital. The serum sodium was 106 at that time, and he was treated in the hospital. 2 to 3 days later, patient went into altered sensibility. When examined, patient was comatose, bilateral rigidity of the upper and lower limb, plantar both upgoing. And patient had this interesting finding in ocular cephalic testing. So see the ocular cephalic, I did the ocular cephalic. See, what did you observe? Turning the head to the left side, eyeballs go to the same side. The slow deviation. See this. Again, go to the same side. Again, go to turn to the right side, what goes to the right side. So I'll show another video which is more easier to make out. I can look at taking the picture from behind the head. To the left, I go to the left side, right, I go to the right side. So what is this phenomenon? In fact, I was not knowing this condition before. I was perplexed to see this finding for the first time. So such literature found this called geotropic alternate gaze deviation. Now this MRI was taken 2 weeks after the ictus was showed. Initial MRI was normal, showed classical central pontine myocarditis. And both central, not only pontine, but extra pontine myocarditis. Now, in fact, this particular condition described in Jacob-Russell disease. But it was not described previously in central pontine myeloma. This is one case where it showed this finding. So when head was turned to one side, the eyes very slowly deviated to that side. Autopsy, one patient had seen lesions compatible with pan-encapsulate type of CJD. Pretecal area of the midbrain showed permanent lysis in that patient. Pathogenesis is not known. Mostly due to the combined reception of the direct and indirect frontal light field to the brainstem pathways, plus impairment of the superior colliculus mediated saccadic pathway, whatever it is. So that's the presentation. Okay.
Sir.
Nice, very good, sir.
Okay, this is the year presentation.
Thank you, sir. Thank you very much, sir.
I'll go to my presentation.
Yes, sir. Two doubts, sir. In case of geotropic alternate gaze deviation, is there anything to do with the vestibular system or something?
No idea, Soumya, because I do not know. This is the what I have mentioned is the pathophysiological mechanism postulated in that article.
Okay.
I do not know.
Then the lid lag that you have shown, no, sir. So
Yeah.
myasthenia, myasthenia also will have that lid lag, no, in certain cases?
No, myasthenia will not produce lid lag. Because why? In myasthenia, I call it true ptosis, but lid lag will not be there.
Okay.
Lid lag indicate that the eyelid is not following the glow. That means that something is preventing from the relaxation of the superior LPS. That's sensitive fibrosis also LPS.
Okay.
That's restrictive ortholopathy. Okay, I will go to this. Screen visible now? Screen is visible? Yeah.
Sir, I have
Yes,
a question.
Yes, sir.
Yes, sir.
Yeah, Butch, you wanted to ask me something, Butch?
Yes, can you just clarify a little bit the mechanism of lateral position of the eyes in central lateral medullary infarct?
Okay. In fact, for that, that will take some time, but still I will try to make you understand. This is because there is an area in the vestigial nucleus called the FOR, the oculomotor region or the vestigial nucleus. The function of the vestigial nucleus, this FOR, the oculomotor region vestigial nucleus, is to produce two functions. It produces a push for the contralateral saccades and produce a brake for the ipsilateral saccades. So, for example, suppose I want to look to the right side. My lateral gaze, right lateral gaze is acting. It pushes towards the right side. But as you know, all cerebellar lesions, cerebellar function is to produce make the movement correctly to that point of fixation. It should not overshoot. So towards the end of the contraction of the saccade to the right side, and towards the end, the FOR will get stimulated. What the FOR do will, it will stimulate the action of the FOR goes through the contralateral pontine gaze center through the hook mandibular present. So it can activate mean towards end of the saccade, the contralateral saccade will get activated. So it produces a brake for the ipsilateral saccade. So if you got a right-sided gaze movement towards end of the saccade, this FOR get activated and produce the contralateral saccade, so that it produce a brake for the ipsilateral saccade. So what happened means that in cerebellar lesions, what are the pathway which carries this one, that the brake is lost, which will overshoot. Okay, if the lesion is in the inferior cerebellar peduncle, the overshoot is to the same side. If it is superior cerebellar peduncle, to the contralateral side, because depend upon which part of that the hook mandibular muscle is affected. That is the mechanism of this overshoot. I think I will explain a little more precisely, detailedly. I got a full diagram in that I prepared this, the pathway, I've animated it. I can show it next class if you wanted to show, if you want me to show that.
Some other time. Thank you.
Then only it will become easily. And if I say like that, may not understand to everyone is that easily. But if you show the animation and the pathway, it will be easy. Okay. Next class, I will do that.
Thank you.
Okay. Thank you, Vijay. So this first, it's a short case, then I'll go to the good case later on. In fact, this lady came with a complaint of percentile tinnitus of the right ear continuously for the last 3 years. She said she cannot sleep because of this disturbing tinnitus on the right side. It became less when she does breathing exercise like pranayama. This is a story, it's in Malayalam, still I will show, you can easily make out what exactly. 3 years, English for 5 months. Continuously. If you take the breathing exercise, it becomes less.
Breathing pranayam
Okay, that's the story. Okay. Now, examination CNS is normal. I oscillated over the year and mastered, there was no brewing. So, what investigation you need now? I'll give you the investigation.
MR
I came with
Vinod.
MRI.
MR
Okay.
Vinod.
MRI, okay, everything else. MRI was taken. This is the MRI. This showed some features sensitive of increased lateral tension. See, it's got a tortuous optic nerve and slightly more widened optic nerve. See, you can see that. It will show the video once again. Okay. Then look for other features of raised lateral tension. There's got a piece in the sagittal cut. So the question is, she had two features. She has got a tortuous optic nerve with slightly widened optic nerve sheath surrounding the optic nerve, and she has got empty stella. But she has no history of any features of raised angle tension, no papilledema. She has past history of migraine. That's all.
Sir, can you just show the sagittal?
So, yeah, sure. That is sagittal. I'm sorry. There's sagittal cut. I'll fast forward one by one. Sagittal cut. Okay. So question is, was it IH? But she has been having this tinnitus for 3 years and increased for 3 months. She had no headache, but persistent migraine. She had no clinical features of increased angle tension, no headache now, no papilledema, no transient visual obscuration, change of position. She's also not the classical category of an IH patient, not obese. Now, what else would you like to do?
MRA with MRV.
Okay. So, could this pulsatile test be due to some vessel abnormalities like AV malformation or vessel kinking? That's the next thing. So, the best investigation will be an angiogram, no, rather than MR venogram, things like that. We can find out both veins and arteries by doing a DSA. So, what will you do? CT angiogram was done, not DSA. CT angiogram was done. CT angiogram was otherwise normal. But the radiologists picked up some interesting findings in this patient. This is the carotid canal. This is the eustachian tube. Normally, there is a bony wall between the two. That is the extent here on the right side. That is normal on the left side. I will show the entire CT. That is the carotid canal. That there should be bony spur there. You can see the opposite side that is there. And the distance on the right side. Okay. So I'll show this static picture. There is a dehiscent bone between the eustachian tube and the carotid canal, the carotid artery. But here on the opposite side, that bone is present. So is it because of the transmitted pulsation of the carotid artery which is producing this tinnitus? That's a question. You can see the coronal cut also, you can make it out. The dehiscent bone here, that is intact on the other side. That's the one. Dehiscent. That side, that side. Okay. That's a normal. Okay, so the dehiscent bone between the eustachian tube and the carotid canal. Now the question now is it pulsatile tinnitus due to the dehiscent carotid canal transmitting the turbulence of the flow into the ear? That's the next question you have to think of. So, yeah. Okay.
Sir,
So,
yes, sir.
yeah, can continue now. Okay. So radiologists picked out another finding. has got a divertic, jugular diverticulum. This is the vein, the jugular vein, the inward sinus is much more enlarged and producing a deficit of the mastoid air here on the compared to the opposite side, the right and left. See the sigmoid diverticulum. This is now the or normal on the opposite side. See the mastoid air cells are deficient here. That's also disrupted. So you can see the vein, the sigmoid vein, sinus there. It's abutting the extend bone. The bone is absent on the right. Here it is not. There's no problem. Here it is abutting there. Again, you can take a problem. So the question now is the patient think what will you do now? So he has got three problems now. Whether it is age, it can be pulsated in intercession. Is it due to the arterial pulsation transmitted through the eustachian canal through the or is due to the jugular or sigmoid diverticulum where the venous pulsations are transmitted to the ear. So, how to sort out this issue?
CSF, sir.
Venous pulsations, because it is reduced by doing maneuver.
Okay, so I did these things. First, I did the Valsalva, but I will on doing the Valsalva. It disappears. Tinnitus disappears on doing a Valsalva maneuver. Second, next I press the external jugular vein and find out the tinnitus. What happened to the tinnitus? It disappeared. No sound now. Now its sound has come back again. On pressing the sound disappears. Then what I do is again the tinnitus disappeared. Next I press the carotid artery to find out whether that carotid diction, the wall of the carotid wall is responsible for that. I press the carotid artery. But she said there is no, it is persisting. The tinnitus does not disappear. Now the question that what we can exclude is that it's unlikely to be a turbulence in the carotid artery because that disappears, did not disappear with carotid occlusion. Now with the venous block or that disappears. So is it due to sigmoid diverticulum or IAH?
Sigmoid diverticulum, sir.
Why not IAH?
Because there is no other features of IH like
Correct. There is no features of IH, but correct. Sometimes IH patient may not complain of headache at all. I agree with you perfectly. I also feel more likely to be a divertical. But what other tests specifically you can do differentiate the two?
Perimetry we can do, sir. Perimetry.
CSF, sir.
Yeah, you have to do
CSF study.
CSF.
Yeah.
No, you take out the CSF. If it is to IH, once you remove the CSF, one you can measure the CSF pressure. That will be elevated. Second thing, when you do the tab, take out the CSF, the tinnitus will go away. If the pressure comes down, tinnitus will also disappear. That's the thing which you can do. So, but the problem, even if by blocking the external jugular vein, will make the tinnitus disappear even in IH. So even IH pulsations can disappear by pressure on the jugular vein. So patients advise CSF study and look for the disappearance of the tinnitus after LP and CSF pressure. However, the patient she said she will come for admission. She never turned up for admission. Because she got frightened by the LP study, CSF study. Okay, that's a short case only. I'll go to the proper case.
Sir, that can be due to a fistula, sir. Maybe due to a dural AV fistula.
Ah.
But that one.
That won't disappear with the venous occlusion.
Yes, sir. Yes, sir.
Because the pressure is high in the neural AV fistula. And there is no bruit, it can oscillate outside. But then you not be there always in neural AV fistula. And in that case, usually find in angiogram, you may find neural AV fistula also. Angiogram pressure was normal. And not the DSA, only CT angiogram was done. Okay, I'll go to this case. This is a story of a 24-year-old male. History of weakness of right hand in the form of difficulty in taking heavy objects for the last 4 years. His tendency for the head to go backward when the patient tries to get up from bed. No difficulty in walking or climbing stairs, no sensory complaint, no positive family history. So, weakness of right hand in the form of using the difficulty in taking heavy objects for the last 4 years, tendency for the head to go backward when the patient tries to get up from bed. This is on examination. He had bilateral facial weakness. Orbicularis was weak. A lower facial pulse is also there. You cannot pout the cheek fully well. A weakness in the neck plexus. Neck extensions were normal. Shoulder elevation was normal. On hip abduction was weak mildly. Biceps was, the hip abduction was normal, sorry. The biceps was weak, shoulder abduction was normal. Biceps was normal. The wrist extensions were weak. It was weak. Finger extensions were weak. Finger flexors were also weak, but more weakness for finger extensions. And grip was weak. Finger extensions I checked again once is significantly weak bilaterally. I started examining the small muscles of the hand. Abductor pollicis longus was weak. Plexus pollicis only just one, not weakness. Abductor pollicis longus weak on both sides. Plexus pollicis longus was weak. Extensor pollicis longus also weak. But plexus pollicis brevis was normal.
That is good power.
We thought that power is good. Brevis is good. But again, check the longus, that is weak.
But it is
Then the opponent is also normal. There is no, you could oppose with the easily without any problem. Then the intrusive is okay, not much weak. Relatively good power compared to the other muscle, long finger plexus. That's a good power. There is no common sign. The intrusive appeared normal, not much weak. significant neck weakness, and the trunk also cannot flex properly. Fever cell could not be checked because anyway, it was not negative, negative, whatever way it is negative, because the abdominal muscle was equally weak. The only muscle parameters are all normal except the EHL, all muscles are normal. That is mildly weak. All reflexes were diminished. Abdominal reflexes were intact. Lower limb fluids are also diminished, just elicitable or even absent. Ankle jacks are also absent. Landoverous flexor. Sensations are all normal. Make him walk about. Now it will be the examination shoulder muscles. I will show the next video. Yes, got that winging of the scapula and the arching, the truncal arching is present. If we do the forward abduction, the trunk goes backward. Filling the trapezius is weak. Serratus was normal. Pectoralis was normal. And she has got this scapular hump, the so-called polyheel, something like a polyheel sign. It's got multiple heels are seen. You can see the scapular sign. So on examination, it's called bilateral facial weakness, both upper and lower part, mainly for, both upper parts, mainly orbicularis oculi. Rest of the cranial is normal. Marked weakness and neck flexes, extension normal. Motor system scapula, hump, and axillary folds are present. Weakness of both trapezius, the trunk arching sign is positive. No weakness of the serratus anterior. Upper limb deltoid normal. Biceps mild weakness bilaterally, grade 4 plus. Triceps normal. This extension mildly weak bilaterally. Then weakness of finger extensions, finger flexes, flexor pollicis longus, extensor pollicis longus, abductor pollicis longus. But marked weakness was for the finger extensions. And flexor pollicis longus only grade 1. Flexor pollicis brevis opponents normal. Intrusion, questionable weakness of ADM, intrusion adductor pollicis. Because we are not sure about that weakness. No Beaver's sign, he could not get up from supine position without support. Lower limb, no weakness of any proximal distal muscles except weakness of both EHL. DT all absent, abdominal plus present, sensations no. So where is the localization and what's the likely diagnosis?
Sir, is there any myotonia, sir?
How do you know this myotonia?
Sir, was there a grip myotonia, sir?
Okay, let us see.
Sir, was there a grip myotonia when you examine, sir?
Now, I'll show you, I'll show that thing. So first thing is it muscle disease or anterior muscle disease?
It's a muscle disease, sir.
Muscle disease.
Why?
Muscle, sir.
Selectivity of muscle.
Yeah, very
More
good.
selectivity, sir.
Yeah, symmetrical selectivity. And most important clue, which I already told my first talk, that if mod muscles have a normal power, intro a normal, flexor pollicis brevis normal, flexor pollicis is longest, is very markedly weak. So that's a point which strongly considered in some myopathic disease. In marked weakness of forearm muscles with good parasmon muscles. Now, which muscle disease? Is it FSHD? Because got that polyhedral sign, bilateral facial, neck muscle, has got a scapular hump. The facial scapular muscles there deltoid, polyhill sign scapular hump and axillary folds. So NCV was normal. So CPK was 912. Okay. Blood was otherwise normal. Now, in fact, one may superficially think it is FSHD. Okay. But somebody pointed out there could be a myotonia or not. Look at this video once again.
Grip myotonia.
ഇത് മടക്കി പിടിച്ച ശരി മുറുക്കി
Is it a grip myotonia present or not?
മുറുക്കി പിടി മാക്സിമം പിടിച്ചേ.
Yes.
Yeah, but we are not certain. No, it can suppose you've got a extensive weakness, a marked extensive weakness that can mimic that.
നൂർത്തെ മടക്കി.
This I did in the first video also. This I have shown. Okay, suppose the significant weakness of the extensor, finger extensors, it may appear like a myotonia because the flexors are relatively overacting, so it did not extend fully. So do one thing, see this abnormality, examine him once again to find out that myotonia is present.
അങ്ങനെ മുറുക്കി പിടിച്ചേ. വിട്ടേ.
It looks like a myotonia, but again we are not certain
ഇങ്ങനെ
whether it is to be.
നൂർത്തെ.
Now it becomes much better now. That point favoring a myotonia.
നൂർത്തെ മടക്കിക്കേ. നൂർത്തെ. ശരി ഇനി ഇരിക്കട്ടെ.
So what will you do now for it?
MG.
EMG.
Percussion myotonia.
No, clinical.
I close the eyes.
Percussion.
Percussion
Percussion myotonia.
Forceful close of the eyes.
Percussion myotonia. Okay. So this is a percussion myotonia. There is no myotonia. This ideal muscle test is this one. So what will you do now?
Look for tongue
At
myotonia.
APB, sir.
Tongue
APB
myotonia.
muscle.
Percussion APB.
Very good, very good. Perfectly right. So now the thing is that you have to think yourself why it is not, there's no convincing myotonia in that muscle. Is the absence of myotonia due to associated significant weakness? That also you have to keep in mind. So this ordinary myotonia, if the patient is unable to elevate due to myotonia, this will be invariably there. But if that muscle is paralyzed significantly, you won't get myotonia. Because the muscle has to contract, no? So your finger muscles are grossly weak as you see at the examination. So you have to do a muscle with relatively good power. As you correctly pointed out, which is the relatively good muscle power, thigh and thenar muscles. So check the myotonia in the index muscle.
കമ്പയർ ചെയ്ത് തളർത്തിയിട്ട മോനെ.
See, beautiful myotonia is there.
ഈ കേതുവരണം അത്ര obvious അല്ല.
The rest again is the other limb also it's not there.
ഉണ്ടല്ലേ?
And on repeated tapping, that improved. That is there on the first tapping. In the second and third tapping, its amplitude comes down.
കൊടുക്കല്ലേ?
Then become less. So-called common phenomenon. Solely confirm EMG. EMG was done.
ഓൺ ചെയ്തോ? ഓണിങ് പൊട്ടിക്കോ?
Just move the needle. So there is no doubt about the myotonia now. So did the distal muscle also distal? The classical reviving motorbike sound. So the diagnosis is what? What is the diagnosis?
Myotonic dystrophy.
Myotonic dystrophy, yeah. So in it's got a myotonic dystrophy. Now, the point I wanted to bring was that this particular finding. So you look at the body like this, what may easily suspect is FSHD. So when he started undressing, the first thing I suspected was FSHD. But examination only I could make out this, the hand was not opening that freely as the dog has picked up. See, look at the shoulder. If you want to see this thing with facial palsy, the immediate spot is FSHD. See the polyheel sign? He has got that scapular hump. Okay. So always look for the myotonia in such suspected myopathies. Okay, any questions?
Sir, so seeing is not believing.
Correct. So don't make spot diagnosis. Okay, examine the patient properly. Lesson.
Sir, there is something called prom something like that. That is a
Yeah, that's correct. Prom is the myotonic dystrophy type 2. In
But
type
here the prominent the proximal muscles are there, unlikely to a myotonic dystrophy type 1, no sir. They present usually with distal more than the proximal.
Yeah, here the distal muscles are weak also. He has got hand grip is weak, finger actions are markedly weak. In prom, the proximal muscle will be more weak than the lower limb is more affected. Here, lower limbs are totally spare, and they usually have a hypertrophy of the muscle also. But here, upper limbs are affected. That's also classical myotonic dystrophy type 1. There will be high variability. One peculiarity of myotonic dystrophy is that high variability in the phenotypic expression. One member may have only frontal baldness, other patient may have only testicular atrophy. Some has a minimal muscle weakness, some will only myotonia. That variability will be tremendous in highly penetrant, but the expressibility is highly variable in myotonic dystrophy.
Any positive family history, sir?
No positive family history.
It's a rare reflexia. Is it constitutional?
I may, yeah, because even the normal muscle it was absent, so must be constitutional, as you correctly said.
Neuropathy can be associated with myotonic dystrophy.
But here every muscle is a global hyperreflexy. Even the knee jerkers are also hyperreflexy. But you myotonic dystrophy, I don't know neuropathy is there. Diabetes can be causes in diabetes which can produce, but otherwise per se it will not produce neuropathy.
But FSHD, the reflexes can be absent.
Yeah, it can be absent, but not to this degree like this. The normal muscle you don't expect to be absent.
Okay.
Okay, shall we go to the next case?
So we don't have any explanation for the absent reflexes in this patient.
Yeah, it's a many times you find that no patients who are little obese, you will have hyperreflexia is very common. If you do the conduction, everything will be normal. His conduction is perfectly normal.
Okay.
Yeah. That may be constitutional.
Okay.
I think shall I have time for one more case? Yeah,
Myotonic dystrophy can have neuropathy. Up to 1/3 of patients can have neuropathy. There are reports, sir.
Oh, no, maybe I did not know that. You may be right. Myotonic dystrophy, no?
Yeah.
Yeah, correct.
Type 1 can have neuropathy.
Okay, right. That is, but his conduction is normal here, so I may not be related to them.
Yes, sir.
Okay, I'll go to the one more case. Okay.
Okay, sir. Thank
you. Yeah. History of tendency for the head again fall backward for the last 3 months. He's a 17-year-old male. Dysarthria for 2 months. And dysarthria is more on continued speaking. And dysphagia for 2 weeks. Okay. This is the boy. He's going backward like that. When he gets up. Lost dysarthria.
പേശ് വ്യത്യാസം മതി എவ்வளോന്നാളാ 2 മാസമാச்சு പിന്നെ ഇറക്കം കഷ്ടം ചൊന്നിട്ട് രണ്ടും പോതും തുടങ്ങി
2 weeks.
കഴിഞ്ഞപ്പോൾ എല്ലാം ഒരേ മാതിരിയാ പേശി തോറും കൂടി വരുമാ പേശി തുടങ്ങുമ്പോൾ ക്ലിയർ ആയിരിക്കുമാ கொஞ்சம் കുറയുക ഓക്കെ
It takes in the early morning it is less, but continue to speak it become worse. So an examination.
മുകളിലേ பார்த்துக்கோ മുകളിൽ பாரு வரல பாரு
Ocular movements were normal.
பார்த்துட்டே இருக்கணும் என்ன
No fit.
நேரே பாரு
Pupils normal, reacting to life.
வரல பாரு இங்க பாரு இந்த பக்கம் മുകളിൽ കീഴே சரி கண்ணு நல்ல ஜோரா மூடு நல்ல முடிக்க முடி பிடிச்சிட்டே இரு விடக்கூடாது சொல்லு சரி கண்ணு தரேன் சரி பாதறீங்க சொல்லுங்க நாக்கு நீட்டு
Tongue is bilaterally wasted. You can move the tongue in either direction.
இடത്തോട്ട് തള്ളു ചൊല്ലു
But fasciculations on the tongue.
போதும் பாரு கழுத்து அந்த பக்கம் தள்ள
Weakness of both sternum.
தள்ளிப்பிடி தள்ளிக்க இந்த பக்கம் தள்ளி பிடிச்சோ சரி முன்னாடி தள்ளிக்கோ தள்ளிப்பிடி பேக்கில் தள்ள
Keep neck extension was good.
தள்ளிக்கோ
Mild weakness up to the small muscle, not very convincing. Tone is normal. He has thinned down because he's got that higher thin. Abductors were weak bilaterally. Reflexes also plus.
மடக்கிக்க இது மடக்கிக்க மட்ட நூத்து வை
Biceps is normal.
நூத்தி போக்கு
Mild weakness in the wrist extension.
ഇത് പൊക്കിപ്പിടി വേണ്ട അകത്തി പിടിച്ചിക്കോ
Finger flexors weak. And mild weakness of the finger and interosseous also.
മുറുക്കിപ്പിടിയാണ് ഇത് മുറുക്കി പിടിച്ചു
Finger flexors were good power.
വിരല് മടക്കിപ്പിടി
That is a good power. Extensions were more weak.
വിട് ഇതിപ്പിടി മുകളിൽ തൂക്കി പിടിച്ചിക്കോ എന്തിരു പാപ്പം എന്തിച്ചോ
Trunk muscles were normal power.
എന്തിച്ചോ
Neck muscles was easy. But you could get them.
വിട്
Lower muscles are all normal.
പൊക്കിപ്പിടി മുകളിലോട്ട് പിടി ഇത് പൊക്കിപ്പിടി
Nature was also normal. Reflexes upper limb normally elicited. Maybe biceps supinated decreased. On the left side, it is well elicited. That is also normal. On the right side, biceps supinated decreased. Triceps is normal on the right side. That is normal. Left triceps is decreased on the left side. Finger pressure is present on the right side, absent on the left. It's also present bilateral. Abdominal flex is intact. Here the angle checks were normal.
ശരി കൈ മുറുക്കിപ്പിടി
Plantar flexor.
இந்த குத்துதெல்லாம் தெரியுதா
Sensation is all normal.
இதெல்லாம் தெரியுதில்ல இது கிரியிருப்பு தெரியுதா இது தெரியுதா இந்த தணுப்பு தெரியுதா தணுப்பா தெரியுதா தெரியுதில்ல
Temperature normal.
ഇപ്പം
Joint is normal. Is the gait of the patient. Gait is normal. Get up from the squatting position. So, cranial examination, restricted palatal movement, tongue wasted and weak bilaterally. Weakness of both sternomastoids, neck flexors are weak, extension is normal. No deafness. Motor system upper limbs, weakness of both deltoid and biceps. Triceps normal. Weakness of which extensions, finger extensions, extensor pollicis longus, and all most small muscles in the upper limb. Finger flexors were however normal. Abdominal muscles normal. Lower limb, all muscles were normal. The right upper limb decreased biceps and supinator, but right triceps is normal. The left upper limb, left biceps supinator normal. Left triceps, however, is absent. Finger flexion normal. Abdominal flex normal. Plantar flexor, lower limb flexors normal. Sensations normal, gait normal. So, where is the localization?
Is the muscle
Minor junction, sir. Minor
Anterior
junction.
tonsils.
But he has got significant wasting of the tongue, no?
Bulbar of the, I mean, the
Musculoskeletal.
Yeah,
Sir,
but it's not the
sir,
tongue. Yeah,
Kennedy's disease, he has gynecomastia as well.
it's got gynecomastia also there, right?
Kennedy's disease.
Yeah, but the distribution of muscle is not actually in the Kennedy's distribution, but it's a possibility you have to keep in mind.
Anterior tonsil.
Yeah, anticonception, juvenile motor neuron. Motor could be motor neuron disease.
But the wasting
Madras
of the
motor neuron
tongue is
disease,
slightly
sir.
old, sir.
But
Wasting
no,
of the tongue in this age group is quite odd.
okay. So
Skull-based syndrome. Could be a skull-based syndrome. Skull-based syndrome.
No, it's not skull base. Upper limbs are also affected. It's got weakness of the small
There could
muscles.
be
Proximal distal.
an associated syrinx.
So what do you want me to do?
MRI.
MRI, he came with MRI, he came with already an MRI that is normal. Cervical spine as well as brain was done.
EMG.
Okay, EMG was done. I will show the EMG. I got only EMG innovation. Other muscles I could not definitely get any speculation, but this FDI. Slightly smaller, but the base normal. That is the FDI. The rate of the biceps. Again, no spontaneous activity. Then from the tongue shows the increased motor unit with the fast frequency impairment. Motor unit sparing frequency. Also decreased. Then did from the left APB. It also did not show spontaneous activity. The motor units were normal. So was it MND? Or we can consider the possibility of Kennedy syndrome or some other treatable condition you have to keep in mind. These are all not treatable. Always keep in mind treatable.
RNS negative.
Pardon?
RNS.
RNS was negative. RNS negative. No decrement response.
For genetic panels.
Trial of
Sir, could it be the
Thyroid.
No, I think the musk antibody has to be sent in this patient because it's got a tongue wasting, even though not typical. You have to keep that possibility in mind, even though RN is negative. So that possibility you have to keep in mind. Another treatable condition in this age group is BBVL, that is brown violet or Leary syndrome, which can say eminently treats a riboflavin transporter deficiency, which treats, always suspected juvenile motor neuron disease with the bulbar involvement, which is possibility in mind. So, but the odd point is,
could it be the Madras motor neuron disease?
Yeah, that's Madras motor neuron disease is one variety. Agreed with you, but that's usually not this pattern. Usually they present something like a juvenile motor neuron, a monomelic inflammatory pattern with wasting and deafness. But that's a possibility which you can keep in mind. But he is steadily progressing. Usually, Madras motor neuron disease is relatively static.
deafness occurs in which one, sir?
Both. In Madras motor neuron disease also as well as in BBVL, deafness will occur. He did not have any deafness. But still,
so what is the dose of riboflavin in this Violetta von Leary syndrome?
I do not remember. It's relatively high dose. But even if it is high dose, it's very cheap. No, it's actually not costly at all.
1000 milligram.
Yeah, even if it gives 1 gram, it will not cost much. It's a very cheap drug. So anyway, I put him on. And send for a genetic panel. Because I want to rule out a treatable, I don't want to miss it. They can also diagnose candies, also you can make out by this doing.
Carnitine deficiency can.
No, usually the conditions would not put in this kind of an atrophy of the tongue and fascicles.
SLC mutations, SLC10 mutation, something like.
Yeah. So I did the genetic testing, but did not turn out to be BBVL. Some other gene came, which I don't know is related to this patient at all. One gene is the hereditary essential tremor, the other is progressive leukoencephalopathy with ovarian failure. None of them fits in with the clinical picture. So I think this is, they say it's pathogenic here, not at all. Even this pathogenic, this is not essential tremor. So that, so gene testing will not give clue all the time. Always has to have a clinical correlation.
This bulbar onset, they'll have extensive weakness of the hands.
Yeah, in fact, I have seen a few cases. In fact, persons with bulbar onset MND in younger age.
Sir, FUS is associated with Andrea Honsel. I don't know. FUS mutation is associated with Andrea Honsel, but I don't know whether FUS.
Oh, okay.
FUS might be associated, FUS gene might be associated with ALS.
Yeah.
Andrea Honsel on described as.
Okay.
So, because they have mentioned as pathogenic, so it is a terminating variant.
I don't know. I have to check up that thing. Now I searched this OM16 that clinical picture does not fit in me.
That FUS gene might have Andrea Honsel.
I don't know.
Could be.
Maybe.
Congenital myasthenic syndrome.
No, this is not congenital myasthenic syndrome. They are not body wasting like this.
In one variant, they produce, no, sir? Slow channel.
There are certain distinct, but here, the tongue is wasted. Usually, slow channel syndrome, you get wasting of the scapular muscles.
So, a trial of riboflavin, would it do any good in this case, sir? Trial?
In fact, I sent the patient for gene testing and put him on riboflavin. High dose riboflavin, send him. Whatever benefit let he have. I don't know whether he'll improve or not. I have seen 2-3 cases in Amrita exactly had presented with bulbar onset, distinct weakness, just tongue muscle and bulbar muscle weakness. Over a period of 6 months, both the patients succumbed. Once you can bulb, a young person, 17, 18-year-old male, this exactly same presentation. So motor disease can occur in this age group as well. As maybe some first variant or something like that is causing it. But treatable conditions like one is musk has to be kept, other is BBVL has to be kept in mind. Both are treatable.
So this brown belt and there is related to facial only. What is that relation?
Yeah, it's related to facial only. Correct. Related to previously it was called facial only. Nowadays the facial only is not taken out. No longer facial only. These all facial only previously were turned out to be BBVL. At that time, gene testing, everything was not available. So that thing has not gone now. Okay.
Sir, I had one patient with a BBVL, but I sent for this mutation, but it was found to be negative only. But he had classical deafness, anti-horn cell wasting and all. 20-year-old man.
Yeah, 70-year-old man.
Yeah, no, 24 something like 24.
No, the other condition is Madras motor neuron disease, which can present exactly like this. Bulbar on spinding plus distal hypertrophy plus deafness. They can have tongue involvement, sensory deafness as well as limb involvement. But that's a very slowly progressive brain condition. Okay. Shall we stop?
Okay, sir.
Okay.
There is one cervico-brachiofacial kind of.
Pardon?
Cervico-brachiofacial variant of ADPY. We didn't know, sir. That you have the bulbar.
PCB variant, you know?
Yes, sir.
That's a demyelinating disease. Here the conduction is normal. It's a pharyngo-cervical brachial variant, PCB variant.
Yes, sir.
SMA will it present like this?
But it's a very rapidly progressive one. That's a, can call it bulbar SMA, okay, right? That but this is not SMA. SMA is slowly progressive. This is a rapidly progressive one.
Prior types of SMA where you can get
GM1 cancer antibodies.
Yeah, that's another condition which can present like SMA and anti-convulsant progressive anti-convulsant disease. But that present is slightly different from this one. It is mainly limb involvement with hyperreflexia.
Sir, that myotonic dystrophy case, sir.
Yes.
Sir, have previously seen anybody with this jutting of this scapular hump, all those things?
No. I don't see. No, I have not seen.
Yes, classic like FSHD initially.
FSHD,
looking like an FSHD.
FSHD only, like, very much like FSHD. So
sir, can this be a combination, sir? Combination of both?
That's very difficult.
Muscles are very prominent, like congenital, very weak Hercules look.
When you look at the patient, as you said, that looked like a FSHD, but myotonia was the one which took us away.
Yeah,
That's only when the hand was not opening that freely well, that's the clue when you start examining for myotonia.
Interesting patient actually. So, but there is a symmetry. That is some odd points are there for FSHD. FSHD usually there will be some asymmetry.
Asymmetry, correct.
And the peroneal involvement may be there, which is not there here.
Right.
So there were odd points were there, definitely.
Points are there, but if you look at the scapula.
Yeah. Looking first look is like FSHD only.
Okay then. So good night.
Thank you, sir. Thank you, sir. Good night, sir. Thank you very much, sir.
Thank you. Good night, sir. Thank you.
Good night, sir. Good night.